Good morning. I am Dr. Saurabh Piparsania. Today I will be talking on HIV infection. The topic will be covered under the following heads: introduction about the HIV virus, the characteristic of the viral genome, what are the different modes of transmission of HIV, clinical manifestations, opportunistic infections, treatment, and a special comment on perinatal HIV. The first case of HIV infection was detected in India in the year of 1986 in Chennai, and first case of reported AIDS infection was detected in Mumbai. In 1989, HIV infection in IV drug user was first reported in Manipur. In 1991, Nation AIDS Control Program was launched by the Government of India, and at present, approximately 5 to 20% of all HIV infected patients are children. Now, what is HIV? The term HIV refers to a human immunodeficiency virus. It invades the helper T cell or CD4 cells in the body of the host. That is, it invades the defense mechanism of a person. The former names of the virus include HTLV3, that is human T cell lymphotropic virus, LEV, that is lymphadenopathy associated virus, and ARV, that is AIDS associated retrovirus. Now, what is AIDS? AIDS is acquired immunodeficiency syndrome caused by HIV infection. So, HIV is the virus that causes AIDS. It is a disease that limits the body's ability to fight infection because of markedly reduced helper T cells. Because of this, patients have a very weak immune system, and patients are predisposed to multiple opportunistic infections leading to death. Now, the definition of AIDS, it is defined as opportunistic infections and malignancies that rarely occur in the absence of severe immunodeficiency. Example, immunocystic pneumonia, central nervous system lymphoma, or person with positive HIV serology who have ever had a CD4 lymphocyte count below 200 cells per microliter or a CD4 lymphocyte percentage below 14% are considered to have AIDS. So AIDS can be defined as the opportunistic infection that are not commonly seen in an individual with normal immune response or a person who have a normal CD4 count. Whenever the CD4 count falls below 200 cells per microliter, or whenever the CD4 percentage is below 14%, then the person is considered to be positive for AIDS. Now, HIV genome. HIV virus belongs to the family of Retroviridae, and genus is lentivirus. HIV virus is a single-stranded RNA virus. It has three major sections: GAG region, pol region, and ENV region. GAG region, it encodes viral code protein P24, P17, P9, and P6. Pol region, it encodes the viral enzyme, reverse transcriptase, protease, and integrase. ENV region, it encodes the viral envelope protein, that is glycoprotein 120 and glycoprotein 41. This is the structure of a HIV virus. Here you can see glycoprotein 120, glycoprotein envelope 41, single-stranded RNA lying in the center, covered by P24 capsule protein, reverse transcriptase enzyme lying next to the single-stranded RNA. It has a lipid membrane, P17 matrix. This is the structure of RNA virus. Glycoprotein 120, it contains the binding site for CD4 molecule, and it is the most common T lymphocyte surface receptor for HIV virus. CXCR4, it is an important fusion-inducing molecule which acts as a co-receptor for attachment of the HIV virus to lymphocyte. So this CXCR4 helps in invasion of the lymphocyte by the HIV virus. CCR5, it facilitates the entry of the HIV into the macrophages. After the after the fusion of the virus with the CD4 lymphocyte, CCR5 molecule helps in the movement of HIV virus into the macrophages. And reverse transcriptase is an enzyme that converts RNA to DNA. Normally, the normal flow of genetic information is from DNA to RNA, and this HIV virus is an exception to the central dogma. That is, it forms RNA from DNA in the presence of enzyme reverse transcriptase. What are the various modes of transmission of HIV infection? It can be transmitted through sexual contact, parental exposure to blood or blood products, and vertical transmission, that is from mother to child. Most common route of transmission in pediatric age group is vertical transmission. Now coming to the vertical transmission, that is mother to child transmission, can occur during intrauterine period, that is when the baby is in the mother's womb, during intrapartum period, that is when the baby is being born, and third is breastfeeding, that is after birth of the baby, when the baby is feeding on mother's milk. These are the three important causes of vertical transmission of HIV infection. Most common route is exposure to infected blood and cervicovaginal secretion in the birth canal. So the most common mode of transmission of HIV infection in pediatric age group from mother is exposure to infected blood and cervicovaginal secretion in the birth canal, that is during intrapartum period. Breastfeeding is an important but least common route, and approximately 30% of newborns are affected in utero, that is during intrauterine period, through mother to child transfusion or through various procedures that are being done in mother, like amniocentesis, chorionebular sampling. These all carry risk of transmission of HIV infection to the baby. Clinical features of HIV varies widely among infant, children, and adolescents. At birth, most infants are normal. Initial signs and symptoms may be subtle and non-specific, and these include lymphadenopathy, hepatosplenomegaly, failure to thrive, chronic recurrent diarrhea, presence of oral thrush. Symptoms which are seen more commonly in children include recurrent bacterial infection like recurrent pneumonias, chronic parotid swelling of the parotid glands, lymphocytic interstitial pneumonia, and in advanced cases, progressive neurological deterioration may also be seen. Based on the clinical feature and degree of the immunological impairment, WHO has classified infection into 3 grades: mild, advanced, and severe. In children age group less than 12 months, 12 to 35 months, 36 to 59 months, and in children above the age of 5 years. Normally, the CD4 level in children below the age of 12 months should be more than 35%. In children between 12 months to 3 years, it should be more than 30%, and 3 to 5 years, it should be more than 25%, and in children above the age of 5 years, it should be more than 500 cells. If these parameters are fulfilled for CD4 count, then the child is said to be normal. Mild immunosuppression is said to be present when CD4 count is less than, when CD4 count is in the range of 30 to 35% in children below the age of 1 year, when it is 25 to 30% in children between 1 to 3 years of age, when it is 20 to 25% in children between 3 to 5 years of age, and when the CD4 count is 350 to 499 cells in children above the age of 5 years. Advanced immunosuppression is said to be present when the CD4 percentage is 25 to 30% in children below the age of 1 year, when it is 20 to 25% in children between 1 to 3 years of age, when CD4 percentage is 50 to 20% in children between 3 to 5 years of age, and when CD4 count is 200 cells to 349 cells in children above the age of 5 years. Severe degree of immunosuppression is said to be present when CD4 percentage is less than 25% or less than 1500 cells in children below the age of 1 year, when it is less than 20% or more than or less than 750 cells in children between 1 to 3 years of age, when CD4 percentage is less than 15% or CD4 count is less than 350 cells in children between 3 to 5 years of age, and when the cells is less than 200 cells in children above the age of 5 years. So on the basis of CD4 percentage and level, the severity of immunosuppression has been classified by WHO. Clinical manifestation: children may present with short flu-like illness, which occurs 1 to 6 weeks after infection. Patient may have mild symptoms in form of fever, weight loss, malaise, headache, soreness in the mouth, oral thrush, soreness in the throat, myalgia, rash, hepatomegaly, nausea, and vomiting, along with lymphadenopathy. Infected person can infect other individuals. So, what are opportunistic infection and at what CD4 count they are common? Opportunistic infection rarely occur in the absence of immunosuppression, and they are present when the CD4 count is less than 500 cells per microliter. The common opportunistic infection are when CD4 count is less than 500. The common infections are bacterial infections, tuberculosis, herpes simplex, herpes zoster, vaginal candidiasis, uroleucoplakia, and Kaposi sarcoma. Opportunistic infection that is commonly seen when CD4 count is less than 200 cells. These are pneumocystis carinii pneumonia. Nowadays it is known as pneumocystic giardiasis pneumonia, toxoplasmosis, cryptococcosis, coccidiomycosis, cryptosporosis, and non-Hodgkin's lymphoma. Opportunistic infection which are common when CD4 count is less than 50. These include disseminated mycobacterium avium complex infection, that is MAC infection, histoplasmosis, CMV retinitis, CNS lymphoma, PML, that is progressive multifocal leukoencephalopathy, and HIV dementia. Now, tuberculosis is one of the most common opportunistic infections seen in HIV infected individual, and the first cause of mortality in HIV infected patient is tuberculosis, that is 10 to 30% cases. So tuberculosis infection is very common in HIV infected individual. Similarly, HIV infection may be more commonly seen in a patient who have tubercular infection. According to the recent data, approximately 10 million patients are co-infected in the world. Why tuberculosis infection is more common in HIV? Because of the modification of the immunosuppression caused by HIV virus, and clinical presentation of TB may have subnormal clinical and X-ray presentation. Tuberculosis infection will have higher rate of MDR and XDR tuberculosis, and in HIV infected individual there are higher chances of treatment failure and relapse in tuberculosis infection. So it is mandatory that in all HIV infected always screen for tuberculosis. Similarly, in all tuberculosis children screen for HIV infection. Diagnosis of HIV infection. Antibody testing is not recommended for children below the age of 18 months who are born to HIV positive mother. Specific viral diagnostic tests are HIV DNA PCR, HIV RNA PCR, HIV culture, and HIV P24 antigen assay. Early diagnosis of HIV infection can be made by HIV DNA PCR or HIV culture. HIV DNA PCR is preferred because HIV culture is technically more difficult, expensive, and time consuming. In breastfeeding child, virological assay should be done only at least 6 weeks after all exposure to breast milk has stopped, and the confirmatory test for the diagnosis of HIV infection is Western blot. So this is a flow chart suggesting how to proceed to a child who has been born to HIV exposed or infected mother. Suppose HIV infected pregnant female delivers a HIV exposed infant who is on breastfeeding or who is not breastfeeding. So first HIV DNA PCR is done 6 to 8 weeks after birth. Now see, there are two possibilities. One, we will consider the first possibility, that is, first HIV DNA PCR is positive. Now reconfirm by repeating HIV DNA PCR to reconfirm the diagnosis. If the second report is also positive, report the child to be HIV infection positive. If the second report is negative, then repeat test and refer the child for further follow-up. Now, considering the second scenario, when first HIV DNA PCR done at 6 to 8 weeks of age is negative, that is negative PCR result, to see whether the baby is on breastfeeding or not breastfeeding. If the baby is on breastfeeding, repeat second PCR after 6 to 8 weeks of stopping breastfeeding or earlier if symptomatic. If second PCR is positive, then refer the child for follow-up and repeat test. And if the second test is negative, report child as HIV infection negative. Now, considering the second scenario of negative PCR test, that is when the child is not breastfeeding, then do second PCR at 6 months of age to confirm the status. If the report is negative, then label child as HIV negative. But if it is positive, then repeat test and refer the child for follow-up. So simple is, first DNA PCR is done at 6 to 8 weeks of age. Repeat DNA PCR. If it is positive, then label the child as positive. If it is negative, as the result is dubious, refer the child for follow-up. If the first HIV DNA PCR is negative and the second HIV DNA PCR is negative, then label the child as negative. And if second DNA PCR is positive following first negative HIV DNA PCR, then as the result is dubious, refer the child for follow-up at HIV center. Now, how do we manage a child with HIV infection? Antiretroviral therapy, prophylaxis and treatment of opportunistic infection and other infection, nutrition, immunization, and perinatal HIV management. These are all the components of managing a child for HIV infection in females and in newborn. Antiretroviral therapy. It is important to remember that ART does not eradicate or cure the patient. It only suppresses the viral replication for extended period of time. Decision to start antiretroviral therapy depends on viral load, CD4 count or percentage, and WHO clinical staging. Indication for starting ART are WHO stage 3 or 4, asymptomatic child or stage 1-2 disease with evidence of advanced or severe immunosuppression, and all HIV infected children below the age of 2 years. These are the indications for starting ART. The drugs that are included in ART are NRTI, that is nucleoside reverse transcriptase inhibitor, NNRTI, protease inhibitor, and fusion inhibitor. Heart is a therapy which is recommended by the WHO for use in patients with AIDS infection. It is highly active antiretroviral therapy. It is a combination of two NRTI with a protease inhibitor or a NNRTI. WHO recommends the use of zidovudine plus lamivudine plus nevirapine as a first-line therapy. Now, the indication of prophylaxis, it is given to all HIV exposed infants starting at 4 to 6 weeks of age and continued till HIV infection is excluded. Second is HIV exposed breastfeeding infant of any age and continue till HIV infection is excluded by HIV antibody testing. That is to be done after 18 months of age or by virological testing. Third indication is all HIV infected children below the age of 1 year, regardless of symptoms or CD4 percentage. And fourth indication is more than 1 year of age in all symptomatic children or children with CD4 percentage less than 25. The prophylaxis has to be continued till 5 years of age. Nutrition is an important aspect in the management of child with HIV infection. Many of these children have failure to thrive, so provide macronutrients and multivitamin supplements as per the recommended dietary allowances. Immunization, as we know that immunization prevents the children from vaccine preventable disease. So in asymptomatic children, all vaccines can be given as per national immunization schedule, while in symptomatic children, all vaccine can be given as per NIS except for OPV, that is live vaccine, and BCG and varicella. Now, perinatal HIV. The risk of mother to child transmission can be reduced to less than 2% by antiretroviral prophylaxis given to pregnant women and to the newborn, certain obstetrical intervention, and complete avoidance of breastfeeding. So, as three vertical transmission can occur during 3 periods, that is intrauterine, intrapartum, and in postpartum period. So, the perinatal HIV infection prevention focuses on all these three important phases of life. Now, considering the scenarios of antiretroviral regimes given for pregnant women. Scenario 1, when ART is to be given to pregnant women for their own health and to prevent mother to child transmission. In this, give a combination of zidovudine, lamivudine, and nevirapine or efavirenz. Okay. In scenario 2, when ART is to be given to pregnant women who are not candidate for ART, but it is being given only to prevent vertical transmission to the newborn. Here we can have two options. In option 1, we can give daily zidovudine in antepartum period, a single dose of nevirapine at the onset of labor, and zidovudine plus lamivudine during labor, followed by zidovudine and lamivudine for 7 days in the postpartum period. Option 2 is give 3 antiretroviral drugs starting at 14 weeks of gestation until 1 week after all exposure to breast milk has stopped. The drugs that can be given are zidovudine, lamivudine, and lopinavir, zidovudine, lamivudine, abacavir, or zidovudine, lamivudine, or efavirenz. Regimens of drugs that can be given to infants born to HIV positive mother. Scenario 1, if mother has received only zidovudine. Now, here we have two options. Option 1, for breastfeeding infant, daily nevirapine from birth until 1 week after all exposure to breast milk has ended. And for non-breastfeeding infants, give daily zidovudine or nevirapine from birth until 6 weeks of age. Second scenario, if mother has received 3 drugs ART during pregnancy and during entire breastfeeding period, then give zidovudine or nevirapine from birth until 6 weeks of age, irrespective of the breastfeeding status. The obstetrical intervention that can be taken to reduce perinatal HIV are avoidance of artificial rupture of membrane unless it is indicated medically, minimization of the PV examination, elective LACS, that is C-section to be performed before the onset of labor and rupture of membrane. Avoid procedure increasing the risk of exposure to maternal blood and secretions like amniocentesis and CVS, that is chorionic villus sampling, is to be avoided. How to prevent postpartum HIV infection or breastfeeding issue? The risk of HIV transmission by breastfeeding is highest in the early months of breastfeeding. So factors associated with increased risk are detectable HIV virus in breast milk, low maternal CD4 count, and the presence of mastitis. Top feeding is indicated when AFAS is met. That is, when the top feeding is affordable, feasible, acceptable, safe, and sustainable. Otherwise, exclusive breastfeeding is indicated when AFAS is not met. Mixed feeding is always discouraged. Thank you.